Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Mark Swinkowski from the Journal of Bone and Joint Surgery.
Well, good morning, Mo. It's time for another Ortho Joe conversation, and I have my cup, and I trust you've got the area is yours, so we're all good.
All good.
We kind of hit a landmark with our last interview with PJ Devereaux on use of new technology in monitoring patients. That was our 10th Ortho Joe podcast. So it looks like the people that have made the decision to start this thing aren't going to cut us off anytime soon. So somebody's apparently listening to what we have to say. So
well, we thank that one person. Thank you. Thank you.
Right. Yeah. So looks like we're on the move. And the other thing I would point out to listeners is that the mailbag at orthojoe@jbjs.org, we're appreciative. We've had a couple of very nice complimentary postings with what we're doing, and we're grateful for that. We've also had a suggestion for a topic. We did an Ortho Joe podcast on diversity and inclusion, and we had an individual from outside North America that suggested that we really do a podcast session on focusing on women in orthopedic surgery, given the high degree of hurdles that women in our field have to go over in order to be in this field, particularly, in any branch of the field, but particularly in academics. So that one we're in the planning phases on, and we intend to interview a couple of women in orthopedics who have done substantial research in this field. And then the other thing that we've got planning is a Ortho Joe session on innovation. And I believe we've got Dr. Ed Harvey from McGill on the line to participate in that Ortho Joe. So we're starting to get some topics lined up now involving other individuals, because it seems like interviewing folks who are knowledgeable in particular areas of our field bring a lot to this. But today we're going to go back to the original format that we had when we were considering this, and I've got to find my journal that just hit the floor. So I was looking through the issue of dated April 21st, and something caught my eye. It was a publication out of HSS that was it's on the timing of knee arthroplasty in relation to when arthroscopy has been performed. And we've had some discussions about the issues with insurance database research, but this one is with a national insurance database, data from 2006 to 2017, where patients who underwent arthroscopy within a year before their knee arthroplasty were stratified by the number of weeks, and they bracketed from 0 to 15, 16 to 35, 36 to 43, 44 to 52. And they looked at the complications, including all types of revisions, as well as infection, loosening, and manipulation. And a big data set, as you might expect from an insurance database, of over 130,000 patients. And of that larger group, 6,000 underwent knee arthroscopy within a year. So they found that there was a pretty strong time-dependent relationship between the timing of knee arthroscopy and complications following arthroplasty. And they suggest, based on this data, that an interval of at least 36 weeks should be maintained between the two procedures. So I think this is a very, very important question. We actually referred into an earlier Ortho Joe podcast on sham surgery to the New England Journal article that came out of the Houston VA on sham arthroscopy, and how that in other studies have influenced the field to not be so quick to jump to arthroscopy for degenerative conditions of the menisci. So we have had a decline in that, I think, in our field, but it's still happening. So I just got a couple of questions for you, Mo. So first off,
Yeah.
do you have anything in ortho evidence that would be pertaining to this question?
Right. So because this is a question, really primarily of prognosis, right, which is a large observational study, as many know who follow ortho evidence, that we tend to focus on the randomized clinical trial. Now, that doesn't mean that this question couldn't be converted at some point to a clinical trial. And we can speak about that maybe towards the end. But specifically, our topics are generally a comparator. So looking at some form that might be looking at, well, arthroscopy at two different time points before, or randomizing, things like that. But no, there's nothing in our database that would specifically address this question. But there's lots and lots and lots of stuff we have on knee osteoarthritis and the whole gamut of, placebos and injectables and, arthroscopy. All of these, I think, in many ways have the same storyline, right? Which is, you're trying to limit the timing or delay the timing to get a total knee arthroplasty. And what are the implications of that? But there's lots here that you can unpack. So I'm happy to get going here.
Yeah. So what would you say were the top 3 interventions if the goal in managing a patient is to delay arthroplasty? What are the most highly evidence-based interventions that we have in the armamentarium today?
Well, so if you look at, there's probably double-digit non-operative treatments that, that we see have used, but, there's your core therapies, right? The core therapies are always, exercise, weight loss, they become part of that initial planning, which, pretty well in every guideline, Mark, are going to be highly recommended. In fact, in the ORSI guidelines that came out not that long ago, and a number of other major guidelines, it's the number one sort of first line treatment. In fact, they even call it the core treatments. But then you get into the secondary stuff, right? Which is what happens when, all those, fundamental approaches. So diet, weight loss, exercise, all that stuff doesn't seem to, there's a plateau reached. Then you get into, okay, are we talking the NSAIDs? Are we now talking into the injectables? Yep. And then you can get further on into arthroscopy. I must say, for most, is not really recommended anymore, largely because of the trials that we've talked about. But let's leave NSAIDs alone and let's get to the invasive stuff. So any of the injectables, so whether it's a corticosteroid injectable, an HA injectable, and even now you're seeing PRP being used increasingly. So let's say we group them as some sort of preventative injectable to manage pain. It's funny, right? The exact same issues have come up. And the same question really has come up is, how soon before a total knee replacement can you do an injectable? And in fact, there's papers that came out of the journal not that long ago. I think it was, I think I have it here. Hang on, I'll get the reference. It's 2019. The paper was entitled Intra-Articular Injections Before Total Knee Arthroplasty, Risk Factors for Infection by Richardson and colleagues. And here's the point. Same thing, large database, 58,000 patients. Ultimately, they identified that it was the cutoff was 3 months, less than 3 months or after. So if it's within 3 months, higher risk. If it's, so the argument was, don't have an injection before totally, before 3 months. This particular study looking at arthroscopy is interesting, right? It's more invasive, and therefore you're thinking, well, possibly you'd extend that that window. And this looks like it's, maybe 3 times that amount now, so about 9 months or so. Yeah. But overall, it's the same kind of messaging we're seeing going across.
Yeah, delay is good and limiting risks.
Right.
Yeah. So in my practice, being I get still an avid cyclist, but a former guy that used to try to go fast. My biggest recommendation to almost every patient with knee OA is get a bike. Make sure the seat is adjusted at the right level, and ride it 4 to 5 days a week for at least 30 to 45 minutes. And it is remarkable. I have an X-ray that would would put me as a candidate for a knee arthroplasty. But I've been able to avoid it for decades just with the bike. So
yeah, so core, like fundamental stuff you've done, and you've never required any injectable, never tried an injectable. Nope. Okay,
nope.
Yeah,
never, no. But
yeah.
I ride, and I know you do too, because I've seen you on.
I've
seen you some of your
But
postings on mountain biking. But
between us, what you're doing on a road and what I'm doing on a trail, very different things. You are 10 times fitter than I am, so I'm not even going to try to discuss what that means. And I like gravity taking me, rather than having to use it against me.
Ever the scientist you are, Mo.
Yeah.
Yeah. Okay.
Anyways.
So let's go back to this paper a little bit. So
Yeah.
What really are the essential weaknesses of an insurance database approach for this question? What would you advise a resident or a young academic faculty are the real issues with such a design?
Well, I mean, and I'll speak as a purist. So, and I'm not saying I'm a purist, but that's, a purist may look at this way. First of all, in the hierarchy is I think it's been drilled into our heads that if you're looking at problems, a clinical trial is important. However, when the question is one of prognosis, one might argue that a large observational study is quite appropriate. In this particular case, a prospective cohort study would be the highest in that hierarchy. Now, where does a database, I think, get challenged? Well, it's not necessarily hypothesis driven, as you know, and I know this has been an issue that you and I have discussed for forever, which is, collecting data for the sake of collecting data is valuable and helpful. But without a hypothesis and a plan, you often have, okay, well, now we don't get to collect the data exactly the way we'd like. So in other words, we have concern about how the outcomes are really being measured. We're not sure if they're fully being measured. We don't really know who's totally getting in. Well, I guess we know who's getting in. We don't know who's not getting in to some degree, right? And that could be a very important group of people.
And in this particular issue instance, the fact that the patients are insured is a big confounder. Everything we know about socioeconomic impact on musculoskeletal outcomes, right?
Sure, right. So there is definitely a group that's being unrepresented in this particular model. But again, so that would be a challenge. So who gets in, who doesn't? How do we actually identify the risk factor, and how confident are we that it's being accurately recorded, right? So again, we aren't. It's different that if you had planned a study with data forms, we say these are the critical information we need, and these are the critical outcomes, and here's the time points. So it's being quality checked through the whole system. When you have almost what would be looking like a retrospective look at a large database, because you're saying it's been collected, we're looking back, you have to go with the cutoffs that patients provided, or you have to go with that. So you're making the best of a situation, which is fine, because remember, in the absence of anything else, this is important information. So it's not to simply say that we should discount everything that comes from a non-RCT, or certainly from a non-prospective cohort study. It just means that we should be aware that there are going to be issues and potential confounders and potential things that we'd have to take into consideration, and we'd have to look at it in the totality of all the other available evidence.
Right.
So
it's really all about confounders, right?
Yeah.
I mean, one of the biggest ones in this particular insurance database was what system or what surgeon treated the patient. Because if it's a very busy, high volume total knee surgeon, the patient might have to wait 6 weeks, which is going to add to that weeks between arthroscopy and arthroplasty. And it's not disease related or symptom related. It's just the fact that they were being treated by a very busy surgeon with a long wait list.
Oh, absolutely. And it is interesting that there are a number of smaller studies. Now, remember, so the value of a large administrative database is that you get precision, right? So if you look at, percentages, small percentages can become very, very important because it's a large number. A number of studies in the, 500 to 1,000 range, or 300 to 1,000 range, a lot of them that are, single surgeon haven't necessarily shown dramatic, effects. And now you can argue that they just weren't sensitive enough to do it. But you can also argue that, some of these other studies were collecting data based on their own in practices. So I think once again, looking at the totality of information will be helpful. Not saying that this is by any means, not one of the more helpful studies out there. It's important to have this number. But the question always is when someone puts a strict cutoff, you and I both know that it's very difficult, right? To say, like, it is difficult to say, okay, if someone comes in just after 9 months, they're good. If they're 8 months, they're, it's not. It's like a p-value of 0.04 or 0.06. It doesn't really, right? It's probably more of a continuum, but we're just not catching it if there is an effect at all.
Right, and this was really brought out in the discussion. The commentary by Morgan Jones from the Cleveland Clinic that these are issues that strict number of 36 weeks is probably not something that should be hard and fast in the clinical decision-making realm. But we should consider getting some time between an arthroscopy and an arthroplasty.
And I guess the other question, right to your very first question, is arthroscopy in the face of knee osteoarthritis evidence-based to begin with, right? So the other question would be we should be really examining when we are even considering it. And a patient who we think ultimately needs a total joint, what would be those specific, situations where you'd absolutely be thinking arthroscopy is needed? So that in itself would be an important, consideration in terms of education around this.
Yeah, I think for the most part, the vast majority of orthopedic surgeons would not recommend it, given the current level of evidence, unless there was a real mechanical issue, a locking that seemed to be related to an unstable meniscal tear or something like that. I believe that would be what the majority of surgeons would say today. And again, Morgan backed that up in the commentary. So now I'm going to really put you on the spot here as a master design of clinical trials. How, if you had an unlimited source of funding for a trial, how would you design a trial to answer this question?
Yeah, it's not an easy one to do because there's not an easy cut point, right? So as much as we say, and that gets back to this, right? So let's say options that exist to us would be, one would be, truly saying, okay, can we experiment with when someone gets an arthroscopy? So we identify a host of patients, we identify that they're going to get arthroscopy, and they get it, but one is going to wait a shorter period of time or a longer period of time after that. And that's going to have to be agreed upon by, the patient that they're going to go ahead. So you could have someone wait over a year for their surgery or someone wait less than that, obviously in that shorter period of time to do that. The challenge with doing a trial with the data set we have now is that I don't know if we actually have enough information that would help guide a trial to be designed. That would be one. The second one would be you would have to be given the system level issues you just talked about, Mark. It's not that easy to be able to control exactly when a patient is going to have, their surgery, although you can within reason, right? And also the bigger question is going to be if you had access to give that patient an earlier procedure and you delayed them in a way, right? That would be a challenge. The same issue came up in the, do you accelerate hip fracture care? Well, you can't randomize someone to delayed care, really. It's not ethical. So all you could do is say, whatever your routine would be, we'll see if we push that up by half, right? We can accelerate you, but we don't probably, we're not going to delay you. We're going to, so that becomes a bit of a challenge there as well.
Sure. What about just simply having an inclusion criteria that the patient is willing to wait a year before undergoing arthroplasty if they agree to have arthroscopy?
Yeah.
And then look at the people that fall out.
You're absolutely right. You're absolutely right. Now, you can imagine someone willing to wait a year may in and of itself be, in itself confounded by, how severe the issue are, how serious it is, and all the other things that would go on. And if someone has milder symptoms, and quite frankly, they have to be, the challenge with this particular trial is, for you to be able to say, we're just going to scope patients, then you'd have to give evidence for why would you be scoping patients as part of a trial unless they have a reason. So the challenge here is going to be getting over the hurdles of actually getting the evidence is always the hurdle. The evidence, it's going to be, well, but no one does that or should do it. Right. But we want to test this other hypothesis, but no one should be doing arthroscopy in this particular indication.
Right.
Good point. Good point. Right.
Yeah.
And that will be the unfortunate cycle. But if you were going to do it, I think that's a reasonable approach.
Yeah. And then there's always if you were able to conduct a trial like this, that the rehabilitation confounders are really hard to measure. Like how do you control for or assess that person that gets the bike and rides 5 to 6 days a week and loses 30 pounds you have to be really, really careful to collect all those confounders.
In my mind, I think I agree with you. And if you look at also from the perspective of, in my mind, if you look at the perspective of where you think there could be a plausible biological rationale for an outcome risk, you can argue that, okay, if you get an actual invasive procedure early, and then you're having another procedure, you could talk about the possibility of infection being, a reasonable link. But when you start talking about revision procedures and other things like that, and rehab and functional gain, it seems to me there's way too many confounders that would have to be sorted out. And who knows? This may be, suggesting there's something happening, but it could very well be, a non-fact if there in fact was a trial. The argument for the infection, though, because it's been also demonstrated potentially also with other, injectables, for example, I think that gets a little bit more robust in the ability, and you can measure that, right? And you would probably argue, though, that someone cycling on their bike is probably not more or less likely to get an infection, right? So, right. But you could argue that their function could be very different, as well as their, risk of revision could be very different.
Yeah, right. Well, given all the difficulties with designing an appropriate RCT for this question, it seems like the editorial process was right, and credit to Chuck Clark, the deputy editor for Knee.
Absolutely.
And the reviewer. So I think it was a good idea to publish this study from HSS, and it's well done and does help us with clinical decision making.
Yeah, and my point, when you have a large number of patients, you've got a cohort, you have a thoughtful group of investigators who have really tried to make sense of that information. I think we've got to get this stuff out. And do exactly what you and I are doing, is having a debate about it, and hopefully or those who listen and want to join this debate can certainly do so. And more and more information is better. And who knows what the truth truly is? But I think the more we discuss it, I think we all get closer to it.
Yeah, no question about it. No question about it. Well, it's been a great discussion, and always an advantage to our listening audience with your expertise and your research design, Mo. So I think we're going to sign off, but just to remind again the audience that coming up, we've got innovation in orthopedics with our good friend from McGill. And after that, we'll be addressing the issue of women in orthopedics. So stay tuned. We'll be interviewing experts in these fields. And until then, enjoy your second and third cup of coffee, Mo. It's been great talking to you, as always.
I look forward to the next 2 sessions too. They're going to be exciting.
Yeah. Cheers.
All right. Take care, everyone.